The opioid addiction is making headlines across the country. Yet managing patients' pain can be complicated. Learn how leaders from Presbyterian Healthcare Services in New Mexico are engaging in a holistic statewide partnership to improve outcomes for patients with substance use disorders. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Petterly, senior writer in AHA's Washington office, and your podcast host. In this podcast, part of the Members in Action podcast series, Joan Risner learns more about the work at Presbyterian Healthcare Services.
Hello, I'm Joan Risner, Director of Member Relations at the American Hospital Association, and this podcast series is part of our Value Initiative, which highlights steps hospitals are taking to improve affordability and value for their patients and communities. These members have implemented strategies that enhance the patient experience, improve quality, or lower costs. In this Members in Action podcast, we will focus on Presbyterian Healthcare Services Substance Use Disorder and Community Collaborative Initiative, a program created to connect those with substance use disorders to healthcare and community resources. Joining me to talk about this program is Dr. Daniel Duhigg, an addiction psychiatrist who serves as medical director for behavioral health for the Presbyterian Healthcare Services. Dr. Duhigg, thank you for joining us today.
Thanks for the opportunity.
Let's go ahead and jump right in. And can you tell me a little bit more about the background of the collaborative initiative that you started for substance use disorder, kind of how it works and the reason for starting it?
It was about 2 years ago that Presbyterian Healthcare Services recognized that there was a need that they had been aware of for some time to address substance use disorders. And the opportunity arose to create a series of programs put together as an initiative to really change the culture across our organization to one that focused on compassion and an understanding of substance use disorders as chronic diseases that require medical and psychological management, just like many other chronic illnesses, and would be devoid of any judgment of a patient or of these illnesses to really increase the quality of care being given. Part of this was because New Mexico is unique in that we have extremely high levels of substance use disorders and a lot of fairly bad outcomes as a result, whether it's from alcohol or from opioids or methamphetamines, tobacco, etc. For many years, we have led the nation in bad outcomes related to substance use. So this initiative was created to really be a wraparound and take as holistic an approach as possible, focusing on, first and foremost, educating our healthcare providers about substance use disorders, their phenomenon, how to identify them, how to diagnose them, and also what is available in terms of evidence-based practice when it comes to addressing different parts of substance use disorders, whether that's the long-term underlying addiction or addressing the withdrawal, for example, opioid withdrawal, benzodiazepine withdrawal, alcohol withdrawal, that we see both in the ambulatory setting and in the hospital setting, but even going further than that and trying to build systems that make it easier for healthcare providers to actually implement the work, but also really focusing on developing partnerships with other community organizations across the state, because it really is a team sport. And because we are a large and a rural state, there are issues that come up with access depending on where somebody lives. So we've really have focused on reaching out and getting everybody as much as possible on the same page so that patients can get consistent approaches to this treatment wherever they live in the state.
So can you give me an example? Say I have a substance use disorder and I somehow encounter the Presbyterian Healthcare Services. I come to a clinic for something. Can you describe what might happen to me as a patient?
What we've been building towards is, first and foremost, that wherever a patient comes into our system, that they are welcomed with a conversation that includes looking for the presence of a substance use disorder. This starts with screening. So, for example, universal screening of patients in terms of screening for problematic use of alcohol, any use of tobacco, problematic use of opioids, or any intravenous drug use. These are the 4 areas of screening that we are focusing on initially, because these not only are drivers of an amazing amount of suffering and medical comorbidities, but they are also drivers of healthcare utilization. And the nice thing also about these is that we have medications to address them. And so coming into the Presbyterian healthcare system, as a patient, you are going to be more likely to encounter a healthcare provider who has been through one or many of our training. So we focus a lot of time and effort on education of our providers. And this is primarily being done because, as many of your listeners will relate to, the treatment of substance use disorders is not something that is focused on in medical training, even though it is such a highly prevalent problem that we encounter in the clinical setting. Most healthcare providers simply don't have the information that they need to be able to deliver compassionate, high-quality, evidence-based care, even though in the realm of medicine, we know how to approach these disorders. So in the Presbyterian healthcare system, a patient is more likely to encounter somebody who, first of all, does not judge them for having one of these illnesses of substance use disorders, and also is going to be able to have a conversation with them and introduce them to different options for treatment, whether that's medication-assisted treatment, non-medication treatment, for example, meeting with a therapist or intensive outpatient treatment. And then we'll also be able to put that substance use disorder in context with the rest of their other medical history related to their difficulty with controlling their diabetes, or struggling with cardiovascular disease, or with depression, anxiety. And so coming to the Presbyterian healthcare system, you're more likely to have these issues recognized and addressed, and less likely to feel judged or ostracized, or frankly, have this part of your health ignored, as happens so often around the country, again, by no fault of any individual or system, but because our medical training historically has just not done an adequate job of preparing people to treat these illnesses.
Can you talk a little bit about some of the community partners who you are engaging with in this collaborative effort? What type of organizations or specialties do they represent?
It's a wide range of different organizations that we have been collaborating with. Everything from faith-based organizations, including churches, where we give them basic training on how to identify these issues and talk to their congregants about them, and also where to point them in terms of people who are seeking help. Also, other clinics, for example, opioid treatment programs, or what most of us call methadone clinics, that are typically independent of large healthcare organizations, but we need to be able to communicate with them. We need to be able to get patients into those services and maintain communication so that there is good continuity of care, for example, from one of our hospitals into a methadone clinic after discharge. Also, just smaller clinics that are around the state. In many cases, we encounter primary care providers, for example, who may be rurally located or in a small clinic where there is not a lot of substance use disorder programming. And we like to partner with them, invite them in, educate them in evidence-based treatment, and then support them going forward in doing this work. One of the ways that we do that is through a weekly tele-echo clinic where we meet in a virtual space on a weekly basis to support people in doing these work, where we hear their patient cases and give them expert recommendation on what steps to take in the management of that patient, which is great for patients because then they stay with their community and with their provider, but then their provider has ready access to expertise that we provide to support them.
Can you talk a little bit about any kind of outcomes that you've seen or the impact that this collaboration has had on patients?
Some of the outcomes have to do, again, with how we prepare our workforce of our healthcare providers to do this work. So I've talked about education. One of the areas that we recognized early on that was needed is to help people get access to the ability to prescribe buprenorphine, what most of us know as the trade name of Suboxone. This is a medication that is extremely safe and extremely effective in treating opioid use disorder, whether that's like an addiction to opiate medications or to heroin. It's also a very effective and very safe analgesic for people who have chronic pain, and so can be a very meaningful and important alternative to chronic opioid therapy with medications such as oxycodone or hydrocodone or morphine. But because of the structures of the federal laws that relate to buprenorphine, you have to go through training and get certified to do that. So from the start, we began offering free certifications in what's called the Data 2000 waiver, which gives physicians, nurse practitioners, and physician assistants the ability to prescribe this medication to treat opioid use disorder. And so that is something that initially in 2017 we did on a quarterly basis. Then in 2018 we provided 6 of those trainings. We will continue to do those trainings going forward. At this point we have put 173 prescribers through that, which for a state like New Mexico is a significant increase in the number of people who have the ability to prescribe that medication. The other thing that we do is we pair that with what we call safer opioid prescribing education, which is 4 hours that cover the CDC guidelines on chronic opioid therapy for chronic pain. And we also provide education on non-opioid medications for chronic pain. This is another area that unfortunately is not well represented in medical education, and yet is one of the most common reasons, for example, for people to seek out primary care visit. So over the last 2 years, we've put nearly 300 of our prescribers through our safer opioid prescribing training as well, again, so that everybody's on the same page, so that we have a consistent approach and knowledge base in terms of what are the regulations about prescribing opioids and about treating opioid use disorder, what is the standard of care, as has this point been defined by the CDC, and what is a rational and patient-centered approach. The result of all of this is patients getting the treatment that is best suited to them when they need it. We see around the country many people, for example, many healthcare providers simply opting out of prescribing opioids or opting out of pain management as a whole. And unfortunately, this leaves patients in a really vulnerable position where they don't know where to get help, and they all too often may turn to taking things into their own hands and trying to treat their own pain, for example, with alcohol or by buying opiates in the street market. And it's not management, and it's disheartening and it's depressing to the patient. And so instead, what we are doing is we're encouraging our healthcare providers to manage their pain, but to do so rationally and safely. So it helps the patients. But the other thing that I've seen is that it helps our healthcare providers as well, because they don't feel powerless anymore. And they also feel like they are able to meet patients where they are and treat them, which is why people get into healthcare in the first place. So it's, in a way, an antidote to the fear around pain management and opioid prescribing, but also balancing that with safety, where we monitor opioid prescribing as a whole so that we can identify any opioid prescribing that is falling outside of safety and outside of regulations, and then address that with individual prescribers. As a result, for example, what we have seen is that over just the last year, that opioid prescriptions as a whole have decreased by 16% from 2017 to 2018 within Presbyterian Healthcare Services. And the number of morphine milligram equivalents that are in this dangerous range of greater than 90 to 100 milligrams of morphine a day have significantly reduced. And yet we are retaining the numbers of people who are on appropriate levels of opioids. Alongside that, because the accidental lethal overdose rate has been such a problem, not just in New Mexico, but across the country, we also include education about naloxone or Narcan co-prescribing as a form of universal precaution. And over just the last year, we have tripled the amount of naloxone that is prescribed to our patients, which helps the patient and also helps their community, because so often naloxone is used on people other than just the person who received the prescription. Likewise, over that same time period, 2017 to 2018, just over the last year, we have increased the amount of Suboxone prescriptions by 50% in our system alone, which makes me very happy because initially, before this initiative was started, the amount of Suboxone being prescribed or buprenorphine being prescribed in our system was fairly low, and we are headed in a great direction in terms of increasing the amount of use of this very safe and very effective medication.
When you think about lessons learned, if there was somebody in the health system in another part of the country who was curious about the success you've had, what might you share as far as experiences that definitely benefited the collaborative's work, or suggestions or lessons that you learned along the way, that if things you might have done differently? Any thoughts along those lines?
In terms of lessons learned, there is a big positive lesson and a big negative or opportunity lesson. In terms of the positive lesson, what we have learned is that most healthcare providers, when you ask them about treating substance use disorders, they might have initially negative attitudes. This is due to the fact that they feel somewhat powerless. They have a low level of self-efficacy. They haven't had the training, and they don't realize how easy and how successful treatment can be. The great lesson that we've learned is that when we really focus on reducing stigma against patients with substance use disorders, presenting healthcare providers with the evidence, not only that we have answers for how to treat it, but that treatment can be quite effective, and that we then support them with things like our weekly tele-echo clinic, that healthcare providers get really excited. And this has been one of the best parts of this experience with this initiative, is that we see people go through this transformation where they're now really engaged and really excited. And I think it's because they connect with what got them into healthcare, which is helping their patients, and they're no longer feeling so powerless when they encounter this type of diagnosis. So that's been just an amazing and very rewarding lesson learned. In terms of a lesson learned about an opportunity, I mentioned that we have put a lot of prescribers through this DATA 2000 certification to get them to the point where they can prescribe sublingual buprenorphine, or what most of us think of as Suboxone. While we had very high numbers of people completing the training, when we got into the data, we noticed that there were very low numbers of people who completed the paperwork and the computer work to actually do the last step and get that certification. After they had already put in a number of hours in the training, they just weren't going through that last step. So that has caused us now going forward in 2019 to slightly alter what we do, which is that when we offer the Suboxone certification, the DATA 2000 waiver training, we will also provide computers at the end of that training and help people complete the process right there on site, so that it's all done, so that we can actually ensure that a large number of people who complete the training actually get the certification, and then we can support them in prescribing buprenorphine after that.
When you think about the future, Dr. Duhigg, do you have anything on your wish list, or where do you see your efforts so far going?
There's still work to do. There are still more people who I would like to engage and excite about doing this work of treating substance use disorders. We have focused a lot on primary care and our general hospitalist services, and now we are starting to focus on expanding to specialty areas such as obstetrics. There has been some interest in addressing pediatrics, for example. Also expanding to different hospitals around the state. Some of our hospitals are in unique communities, and not all communities operate the same way, and not all communities have the same resources. So we're really focusing on tailoring our programs to the specific communities to meet the individual community's needs. I think this is going to help serve people where they live, which is really an important area, so that people get the individualized treatment that they need, and they get it where they live, so we make it more convenient for them as well. And I think that that's probably going to translate into better engagement and better outcomes.
Well, it certainly does sound as though the Substance Use Disorder and Community Collaborative Initiative is having a significant and positive impact at Presbyterian Healthcare Services and throughout the communities of New Mexico. So congratulations. I want to thank you, Dr. Duhigg, for being with us today and sharing more information about this program. It truly is an excellent example of improving quality outcomes to decrease costs, improve quality, and improve the patient experience. For more podcasts or additional tools, resources, and education to help you advance affordable health care and promote value in your community, please visit the Value Initiative's website at aha.org/The Value Initiative. This concludes our discussion today. Thank you for listening.